Thank you very much for your kind remarks. I thank Dr. K.K. Agarwal, Dr. Pawan Gupta, eMedinews team, and with the permission of chair, I will be sharing my thoughts related to sleep medicine and sleep disordered breathing. Sleep, what are the things that can bump in the night and disrupt the sleep? There are more than 84 clinically recognized disorders ranging from insomnia, narcolepsy, parasomnias and snoring. However, insomnia remains the most common sleep disorder. But I will be speaking on sleep disordered breathing. And in sleep disordered breathing, we have an umbrella term related to obstructive sleep apnea, central sleep apnea, CSR and hypoventilation. It is a majority of the patient, 80 to 90% patient with sleep disorder breathing have obstructive sleep apnea, while 10% have CSR and hypoventilation. It affects 9% middle-aged women, 24% middle-aged men, and in general practice, you should see similar number of patients as you see patients of insulin-dependent diabetes mellitus or you see patients of severe bronchial asthma. The same number of patients you should also see in your primary care practice. So there are certain terms, if we know about them, the talk will be easy to understand. So what is inspiratory flow limitation? Inspiratory flow limitation is decrease in airflow due to obstruction. And what is hypopnea? Hypopnea is reduction in airflow by more than 50% with a 4% decrease in saturation. And apnea is cessation of breathing for more than 10 seconds. Since I will be using these terms frequently in next 10 airways. When we sleep, we all know there is an open airway and we sleep and breathe normally. While when there is a small narrowing, there is the tongue falls back and the muscle tension relaxes. This leads to flow limitation while sleeping. And once there is more blockage, there is vibrations of the soft palate and fluttering like the wings of the bird, and this gives rise to snoring. Around 50% of the adult population snores, and all snorers do not need treatment. We are bothered about those snorers in which the breathing stops during sleep, and that is what we call it as apnea. Now there is complete cessation of the airflow because of the falling back of the tongue at the back of the pharynx, and this is known as apnea. Around 4 to 6% of the snorers have stoppage of breathing at night, and this is harmful and it has lot of physiological and clinical consequences. Now in obstructive sleep apnea, we have an open airway which is normal and closed airway. This is the most common form of sleep disordered breathing. Muscles at the back of the airway relax and breathing stops, but respiratory effort continues. So patient is like a sleeping athlete. He will be fighting for his breath during sleep, having lot of sweating, and many a time he wakes up during sleep, and not all snorers have sleep apnea. Now this is the recording. We call it as sleep study. There is a normal pattern of nasal airflow, which is oscillation, then the abdominal movements are normal, saturation, and there is no snoring. While in obstructive sleep apnea, there is stoppage of breathing, complete cessation of breathing at the nasal airflow, and then there is a sudden explosive onset of breath. The patient has extra efforts, the efforts have increased, and there is a decrease in the desaturation and there is snoring. Now we measure OSA severity by AHI, apnea hypopnea index. Less than 5 is normal. In old age also the index increases because of the relaxation of the muscles. 5 to 15 is mild, moderate is 15 to 30, and 30 or more is severe sleep apnea. Patients with moderate to severe sleep apnea always need intervention and they need treatment also. What are the physiological effects of sleep apnea? These patients have desaturations, decrease in the heart rate during apnea, followed by rise, BP drops, and again rise in the blood pressure. What are the various risk factors? Obesity, male gender, postmenopausal family history, facial restructure, and a similar thing we can do in our clinic is measure the neck circumference more than 43 centimeter in men and more than 40 centimeter collar size is again a risk factor for sleep apnea. What are the signs and symptoms? The most common sign and symptom is excessive daytime sleepiness while watching TV, listening to a lecture, doing some monotonous activity while driving. These patients sleep. Obesity, nighttime gasping, choking, witnessed apneas at night by the bed partner, usually in our country is husband or wife. Frequency of urination at night, morning headaches, GER, and depression, hypertension. These are the most common symptoms. But remember, many a time, all patients with OSA do not tell us of having excessive sleepiness. Now this excessive sleepiness, daytime sleepiness is hazardous to the society, for the self and for people at large. If a person is driving, he can meet with an accident, or if he is a pilot, or if he is driving a train or working in heavy industry, he can cause harm to himself and to the lives of other people. While in abroad, for all pilots and these truck drivers and people driving trains, maintenance of wakefulness tests are important. Whether a person is able to maintain his wakeful stage, while in our country we are still in the young stage, and we will be talking about this. Now, what is central apnea? Central apnea is recurrent episodes of apnea during sleep lasting from temporary loss. This is an open airway apnea in which the airways are not closed and there is no breathing effort as well as absence of breathing. A mixed apnea in which there is a early part, there is obstructive apnea followed by the efforts. Now CSR, these are seen in patients with CHF. There is waxing and waning kind of ventilation, sign stroke respiration. Now this is untreated sign stroke respiration. Hypoventilation is associated with COPD, hypopnea. There is a reduction in airflow followed by desaturation. Now what is the cause? Alertness and entertainment suffers, concentration and judgment suffer, productivity declines, risk of accident increases. Sleep apnea is a single key to many locks. It's associated with comorbidities like hypertension, obesity and diabetes. Sleep apnea is the most common identifiable cause of hypertension, obesity, pacemakers, CHF, atrial fibrillation, diabetes, hypertension, CAD. Up to 30% people diagnosed with ASA will have diabetes. Many more will have pre-diabetic condition. 23% men with type 2 diabetes will have severe OSA. Why sleep apnea and cardiovascular diseases are important? 30 to 80% patients have cardiovascular diseases. Sleep apnea therapy helps in lowering the BP and it has got proven benefits in improving the LVEF. JNC 7 classification, sleep apnea is the most common identifiable cause of severe hypertension. Now chronic risk for OSA, there are proof links. 51% patients with stable heart failure and sleep disorder breathing, while in 70% CHF, 37% had OSA, 33% had CSA. Now treatment of CPAP substantially reduces nighttime and daytime BP. Approximate 10 millimeter rise in BP with therapeutic CPAP predicts 37% reduction in coronary artery disease and reduction in stroke. And CPAP therapy increasing LVF by 9% LVF, and many patients with congestive heart refractory CHF, if you put them on therapy for sleep apnea, their refractory CHF improves. Obesity is also associated with sleep disordered breathing, and before surgery we must treat, otherwise it is difficult for these patients to extubate and maintain their wakeful stage. How will you identify? In the clinic we have simple Berlin questionnaire and Epworth sleepiness scale, while sleep study or polysomnography is the gold standard for the diagnosis of sleep apnea. Polysomnography is continuous and simultaneous measurement of various physiological parameters during night involving the neurological channels like EEG, EOG, ECG, EMG, the respiratory efforts, airflow, oximetry, leg movement, snoring, and body position. Now there are different types of sleep studies available like full sleep study, ambulatory sleep study, respiratory monitors. Now full polysomnography is expensive, time consuming, so this is how you hook up the patient for polysomnography. These are the respiratory efforts. Now we have sleep screeners in 2011 and 12 now, which measure about the oximetry and the efforts. These are simple, safe, and can be used at home. So you have a variety of instruments and gadgets available. So this should be available to all, accessible to all, and affordable. Now what is the management of OSA? We have conservative measures, dental devices, sleep hygiene, but the most important is this magic box, which is the treatment for all the things. This magic box is known as CPAP, continuous positive airway pressure therapy. It is the most effective treatment and considered gold standard for therapy of OSA. This was discovered by Sullivan et al. And it is just reversal of your vacuum cleaner. That is how it was designed. You just reverse the vacuum cleaner and it has a pressure varying from 4 to 20 centimeter. How it works? It forms a pneumatic splint at the back of the pharynx or behind the tongue so that the airway doesn't collapses during night. So PAP devices, with the advancement of technologies, we have conventional PAPs, intelligent CPAP and bilevel PAPs. And in CPAP there is a continuous pressure, while in auto CPAP or intelligent CPAP, the pressure varies with each breath, breath after breath and each night. While in VPAP we give a higher pressure during inspiration and lower pressure during expiration, and we have adapted servo ventilators which are used in patients with CHF. And these are the new modern technologies. They look like just any gadget and go well with your lifestyle. And the interfaces is the part which connects man with the machine. Now in ventilators you have endotracheal tubes or tracheostomy tubes. Now we have this nasal masks. So nasal masks come in different shape, full face mask, nasal pillows and nasal mask which connect man with the machine. Now CPAP, the keys to success are reversing symptoms. Perseverance is key. Many people give up before they reach acceptance. So to summarize, prevalence of sleep disorder breathing, 42 million in general population, 30 to 80% patients with cardiovascular disease have this problem of sleep apnea. 50% patient with diabetes have sleep apnea. So we must treat the treatable cause. Before going for all these modern interventions and all, many patients do come to us after PTCA, after CABG with refractory heart failure and other complications. Unless and until you identify the cause, treat it, the disease symptom will not key. If you give paracetamol in a patient of fever, unless and until you see fever is due to malaria, tuberculosis, typhoid, treat the cause. So we must always treat the cause wherever it is identifiable. And methods of treatment I have discussed with you, CPAP, APAP, bilevel, and results of treating sleep disorder breathings are improvement in quality of life and reduction in risk factors for comorbidities. What is the future? The role of obstructive sleep apnea in cardiovascular and other diseases will be better identified and defined, and range of patients will increase. Diagnostic tests have become really cheaper now, costing just around 3,000 rupees to 8,000, 10,000 or maybe 15,000 depending on the facilities and the healthcare facility which we are using. Primary healthcare will be increasingly involved in a long-term management. The role of various treatment devices will be better defined. So a word about sleep medicine. Sleep medicine is clinical medicine. Now it is 2 decades old. Sleep medicine needs widespread identity, accessibility and acceptability by all. Sleep medicine information and easy availability to all is required to benefit the society at large. Thank you very much for your patience hearing.
Thank you, Dr. Chuk.